myself briefly, my name is Steve Bloom. I work at the Yale Alumni Association, and I am, in fact, also an alumnus of Yale. Delighted that all of you have arrived to hear about the changing face of telemedicine, particularly internationally. We have a terrific discussion ahead of us. And before I go there, I just want to remind you that these sessions, which happen every Thursday night at 8 p.m., are courtesy of the Yale Alumni Association, with the wonderful efforts of great alumni leaders such as Xiaoyan Huang, who's also on this call, and many others. And we thank them for their efforts. For those who are on this Thursday night, as a reminder, please join us on any Thursday night at 8 p.m. Eastern Time. Once every 4 weeks, we have a discussion that we call the STEM report, different topics like this one. We also have one called the Human Experience, another called Life and Personal Growth, and a fourth one called Career Pivots. So you won't lack for interesting topics on Thursday night. Behind me, you see the emblem of an online community that all of you are welcome to join, called Cross Campus. 16,000 of your fellow Yaleys have already joined. It's a great place to find networking, community building, and advice. So crosscampus.yale.edu is the place to go to join that community. Without further ado, I'm going to introduce Jia, who will in turn lead this discussion. Jia is a wonderful alumni leader at Yale, and in addition, in the world outside Yale, is a global offering leader at IBM Watson Health. She serves on the IBM Academy of Technology leadership team, and she is, I mentioned before, not only a leader, but the vice chair of the Yale Graduate School Alumni Association. So Jia, the floor is yours.
Thank you very much, Steve. Welcome. Thank you for the great opportunity tonight, and thank you for tuning in from around the world. I do want to check, Steve, can you hear me okay? How's the audio?
Yes. Yep.
Okay, thank you. Thank you. So welcome everybody to tonight's must-see, or this morning's must-see, depends on where you are in the world, Yale STM report. The title of tonight's session is The Changing Face of Telemedicine, a 2021 International Perspective. This event is sponsored by YAA Careers, Life, and the Yale Alum to Alum and Alum to Students committees, and GSAA, which is Grad School Alumni Association, Yale Healthcare Network, Yale Bio Plus Tech. This is part one of an event series on digital health. So I'd like to briefly introduce our three panelists. First, Dr. Huo, who's a professor of medicine at Peking University and the chief of cardiology at Peking University First Hospital. He's the president of World Association of Chinese Cardiologists, president of Asian Society of Cardiology, and the dean of China Heart House. He's a leading cardiologist in China. Professor Huo's research and the leadership focuses on cardiovascular disease prevention, quality improvement, on population management. You'll see in his talk that he's the chief medical officer of one of the largest digital health company in China. So very interesting perspective. I'd also like to introduce our second panelist, Greg Licholai, who's an MD of 95 and MBA. He is Chief Medical Information Officer at PRA Health Sciences. Dr. Licholai teaches at Yale School of Management and is the co-director of the Center for Digital Health. Previously, he was president of rare disease at Moderna, which is super famous these days, therapeutics, and has held numerous other leadership positions in pharma consulting and healthcare startups. Greg has degrees from Harvard Business School. We know that he lectures there frequently, and Yale School of Medicine, and the Columbia and the Boston College. I'd like to also introduce briefly Dr. Xiaoyan Huang, 91. She's an MD, MHCM, and FACC. She is a renowned cardiologist and medical director of general cardiology at the Providence Heart Institute. She's the vice chair of the YAA Board of Governors. Dr. Huang holds degrees from Yale College, Stanford Medical School, and Harvard School of Public Health. Her research focuses around specialty care and the payment reform. She has published on these topics in New England Journal of Medicine and other leading healthcare journals. So as we have all experienced the last 12 months, this pandemic, I mean, personally, from my personal perspective as a patient and a caregiver, it's very interesting to experience telemedicine firsthand. COVID-19 has really posed great challenges and opportunities to the delivery of care in chronic disease management. Today, we have convened these world-leading experts, including 2 practicing physicians and physician leaders in China and in the US, as well as Dr. Licholai, who's the co-director for Yale Center for Digital Health, to share their perspectives on digital health, in particular telemedicine. So Xiaoyan, I was going to ask you, shall we present the charts?
Yes, I am going to share my screen.
Okay, so while we're getting the screen ready, maybe I could ask a first question for Greg. You know, we have all these buzzwords, right? Telemedicine, digital health, virtual health. Could you explain a little bit what is the difference between digital health and the telemedicine?
Yeah, absolutely. And thank you very much. You know, thrilled to be here, and really very nice to be part of the Yale alumni group discussing these important issues. So as you said, I teach at Yale at the School of Management. I have a course on innovation in healthcare, as well as I'm the chief medical officer of a large public company. And you can see from my background here, I hope this confers warm feelings instead of stressful feelings. This is a classroom image from the School of Management. But to address your question, so telemedicine and digital health are part of a continuum of the technology enablement of medicine. Those of us, of a certain age who have really learned medicine from a paper and human point of view, we've been waiting a long time for medicine to start to embrace technology the way most other industries have, such as finance and communications, etc. So briefly, telemedicine is what we're doing now. It's a way to communicate specifically for medicine and medical related issues. Digital health is using digital technology in order to manage health wellness, population health, improve and treat various diseases. So digital wellness really is more like you think about telemedicine as televideo, and Zoom. Think about digital health as online banking. It does, so many more things around your portfolio of health and disease, as it were. And there's many peer-reviewed publications that discuss the positive impact of digital health and chronic disease management that should give us all encouragement that these technologies and tools actually have a very strong impact on disease management. So hope that's helpful.
this is very helpful. Thank you, Greg. Now I'm learning a lot about telemedicine digital health. So we do have a poll. We do want to ask the audience today in terms of the role you play in healthcare. So
originally we wanted to do the poll questions kind of spread in the talk, but I think we're going to do all 4 questions together. As the co-host, I can't see, so I'm presuming, okay, I do see numbers coming in. Excellent.
yeah, we have a little bit technical glitch. We always say that AV is more difficult than AI, so apologize. We're going to do the poll spread out through the through today's session. So,
well, at least at the beginning,
this is the first in the series, so we'll get better the next series.
Yeah, at least at this stage, people are saying they are going to attend our next event on digital health. So it's a good thing that we did this question at the end of our. So 63% of people have voted. Let's go to 7. Well, let's go to 70 and then we'll stop. How's that?
Sounds good.
I see that we have our first comment in the chat box. We should keep an eye on that.
Yeah, so particularly, I wanted to focus this initial event on telemedicine, and I'll go over, you know, the reasons why that's a focus for this this talk. And in our subsequent talks in this series, we hope to expand our coverage to include other aspects of digital health. So we got to 70. So should we, Jia, do you want to review the data?
Yeah, I think that'll be good. I don't have a view of the data, I think, because
Oh, you don't? Okay,
yeah.
no. So that I will go over then.
Okay, thank you.
Wait, so I guess if we end the poll, then everyone else can see the results, right, Chelsea? Okay. Okay, so let's share the results. So can you guys see? So for the first question, what role do you play in healthcare? We have 28% physicians, 6% mental health providers, 9% in the payer business, 18% in technology, 9% in drug device manufacturing, 7% in government policy making and administration, and 45% are patient or caregiver. I may argue that we all are, aren't we, at some point? Or maybe the 55% of people are too confident in their own health. So the second question is, have you had any telemedicine experience? Yes, as a provider, that's 33%. Yes, as a patient / caregiver, 42%. And no, 25%. Lucky you. The third question is, what do you mainly use telemedicine for? Access to routine care, we have 52%. Prescription refill, 10%. Expert consultation, 34%. And new disease diagnosis, 3%. And then 99%. I think we should just end it here, our talk. We're successful already. Excellent. So should we just stop sharing this poll, and then I'll go back to the slide.
To the slides. Yeah, sounds good.
Greg, give an overview. Yeah.
Yeah, I think today we, with all the super experts. We prepared lots of great content. So we think we probably will need to take until 9 p.m. ET, the rest of the 40-something minutes on going over the content, and then we'll have a Q&A afterwards. So it'll be interesting that next Greg will share with us an overview of how this pandemic has affected the global digital health, and what are the expectations for patients, and how has technology being affected. So I'm gonna hand the mic over to Greg.
Thank you very much. I just want to give a brief overview and express that this virtual care channel is growing rapidly. There had been a growing increase of engagement using telemedicine and digital health, but last year, 2020, I think we have to, I'll tell you my opinion, 2020 is the year that healthcare changed in the United States and in the globe, meaning that I think we'll look back on this 1 or 2 years as the year that many things shifted towards the embrace of digital and remote technologies in medicine. And it really just puts us in line with the way many other industries have moved. So there's many drivers behind that. Of course, not the least of which is the global pandemic and the need for virtual care and remote patient monitoring. But there's also many structural changes like increased Medicare reimbursement in the United States, venture funding for digital medicine doubled last year to $14 billion. Of course, this goes into smaller stage companies, but it's a proxy for other significant amounts of finance going into digital medicine. I think we can all acknowledge that the opportunities are enormous. Diabetes digital management is a $300 billion opportunity. In mental health, more than 60% of young people with depression receive no treatment, and telemedicine is expected to reduce costs by over 20%. And just to focus in on one case example, Teladoc, which merged with Livongo last year, this is a global healthcare provider that has over 50 million users just in the US and probably double that across the globe. They operate in 130 different countries and in many different languages. And currently, this merger created a $40 billion company that offers the spectrum of disease management, mental health services, remote patient monitoring, as well as telemedicine. I think this is a virtual health channel that we will expect to grow and continue to change medicine in the future. So with that, I will turn it over to my colleagues to discuss their expertise in what they're doing.
Great. Thanks, Greg. I have these extra slides from you that we can come back to because we did have questions from the audience before we even got started. So we'll come back to that. But today I wanted to share my side of the story as a practicing physician, a practicing cardiologist, and really focus my presentation not as an exhaustive literature review, but really what is happening on the ground in US over the last year. So I'll focus my presentation on 3 papers, actually 2 of them from our own institution. So this first study came out in JAMA Cardiology And the work was led by our own Ty Gluckman, cardiologist. I think some of my team are here. I believe Dr. Spinelli, the senior author on this paper, is here too. So what they did was they looked at the Providence Health System data across 6 states in Western United States. And they looked at the diagnosis, the case rates of acute myocardial infarction, so acute heart attack, from January 2019 to May of 2020. So the top line, as you see, are the case numbers of acute MI every week over the year, until you come to the gray part where we mark the beginning of COVID, starting in late February through March and into May. The gray line is where the case load would have been expected. However, the reality is this dark line where I think you guys can see my arrow, right? This sharp decline of the total number of acute MI diagnoses in our health system. And the second line is this NSTEMI, which I think, to put it into simple terms, is just a less severe form of heart attack. And the third orange line is the cases of STEMI, which is really this crushing chest pain, unbearable discomfort. Often people will end up calling 911. There will be sirens and ambulance and acute intervention. And you'll see that the decline of the caseload is more prominent in the less severe heart attack versus the more severe cases. So the summary points of the study is that we saw an initial sharp decline in heart attack presentation, and the bigger impact is seen in the less severe heart attack because people were delaying their care, and if they were only having minor symptoms of chest pain, they weren't going to the hospital. And what is not shown on that graph, but shown in the study, is that we saw an increase in the mortality rate, especially for people who had STEMI diagnoses, even though the patient demographics, the comorbidities or treatment strategies weren't different. So we saw about doubling of the mortality rate during the initial COVID period. So what this study highlights is that, some of what we do in healthcare is not elective. When a pandemic happens and patient delay in seeking care because we have stay-home mandates or we're not open to face-to-face visits for patients, bad things happen to our population. So with that is really our main driver to figure out how we can deliver care that is not for COVID, but regular care during this COVID time. And here we present our own data in a Providence Heart Clinic in Oregon. So this data was just presented as a poster in the American College of Cardiology Cardiovascular Summit this month. I can't see everyone, so I don't know if my colleague Leslie Jones Larson is here. And so this graph on the x-axis is the month from January to December of 2020. On the y-axis, we plot the number of outpatient clinic visits we see for our entire Providence Heart Clinic group, which is a very big group of 67 cardiologists or surgeons and 40 some advanced practice providers. And we cover 22 clinics over in Oregon. So you can see in January and February, also these red dots are numbers from 2019. And the height of each bar is the total number of encounters we see. So you can see in a regular year like 2019, there are these seasonal variations or monthly variations of the total number of encounters we see. The color coding of each bar in dark kind of blue or green is face-to-face visits. And you'll see normally we are 100% face-to-face encounters. However, the light blue, as you see, are during COVID time, we were seeing patients via telephonic visits, and the orange part of the bars are the video visits. So in this smaller insert of this graph, thanks to Dr. Spinelli's graphing technique, you see how rapidly we were able to operationalize and adapt to the changes of how we can deliver care during COVID. So from January, February, 0% of telemedicine. By the end of April, we were 99% telemedicine. And you can see this, initially we were doing a lot of telephonic visits, but by July, these numbers came down very rapidly. And the orange part, the video visits, stabilized in the latter part of the year to about 30%. So remember that 30%, I'll come back to that number again. So the key points from this study is that we were able to rapidly adapt to the changes, and that speaks to our leadership and our organizational readiness and culture of adapting change and leading change, where we try to stay away from this. I think my psychology colleagues will know this learned helplessness, where doctors often will feel, oh my God, that's one more thing I need to do. All these technology or new payment, and that's just additional burden. But what we've built in our organizational culture is that we want to be leading change. We think with a design thinking, and we make changes, operational changes, using this technique, which I call critical making, so that we design something, try it out. If that doesn't work, refine it and try it again. And that's how we were able to rapidly train over 100 providers, lots of staff and patients, and realizing that when you have to turn 6,000 encounters from their scheduled visits of face-to-face to virtual visits, it's a lot of work from our schedulers, and we were able to do that. So you saw another point I made was the sharp decline in telephonic encounters in July. So why was that? It was because the CMS changed their reimbursement rule such that the telephonic visit reimbursement sharply came down. So we had to then switch those encounters to video visits as much as possible. Overall, our group did quite well in the, so comparing 2020 to 2019, we were only down by 4% of total encounters, which is remarkable given this pandemic. And as I said earlier, the telemedicine stabilized to about 30% in our hybrid clinics in Q3 and 4. What I don't show in here is that for each of our subspecialties, including general cardiology, interventional, advanced heart failure, the percentages of telemedicine was different because the patient population was different. And I'll come to more of this point later on. So financially, what we've done this year is, as I said, our overall encounter was down by about 4%. However, our gross revenue was down by 11% because of the reduced reimbursement with telephonic visits. On the other hand, some of the fixed and variable costs were lower because of the lack of in-person encounters. And also we withheld compensation during Q2 or maybe Q3, one of the quarters of this year, so that overall, in the end, our what's called EBITDA is earnings before interest, depreciation, and amortization was only 4%. So overall, we did well. However, because of this differential between the number of encounters versus the number of gross revenue decrease, we are now being asked by our leaders to maximize our face-to-face encounters. So we're already seeing that in 2021 because we see not only is the reimbursement lower with certain telemedicine encounters, but also we see more no-shows or our inability to connect with patients for these telemedicine visits. Another thing is we find that our downstream revenue from these encounters seems to be lower than face-to-face visits. So we're being asked to maximize face-to-face visits. So I'm afraid, I worry that with all the innovation and success with telemedicine, when COVID is over, we're going to forget all this and go back to face-to-face. So I want to capture this energy at this time and really bring together a lot of frontline clinicians and physician leaders and people in the delivery system so that we can learn from what we have learned already and figure out what lies in our future in terms of telemedicine, because I think there's for sure a special market, special benefit of this modality of delivering care. So the third paper I want to share just came out this week from Health Affairs. This unfortunately is a paper from the other schools, School of Public Health, but it's a very well done study. They looked at 16 million claims data from Optum, from both commercial and Medicare patients. So this is a very interesting graph because a lot of you and my team have thought about, what is, who's using more telemedicine and, what patients is it best for? So on this graph, you'll see on the x-axis is the percentage of total visits delivered via telemedicine during the COVID period. So the first half of 2020 was this study. And then on the y-axis, you see is the amount of decrease in the number of visits compared to the pre-COVID period. So interestingly, there is this line that can be drawn, and you can see in the right upper hand corner in social work, psychiatry, and psychology is in the specialties where there is the most amount of telemedicine delivered. As a result, they had the least amount of reduction in the care that is delivered during this period of time. On the other extreme are specialties like optometry, physical therapy, chiropractic, where their practice relies on patient contact. So you'll see when that their practice suffered most. So the size of these circles indicate how many of the encounters are. So the biggest circle, of course, is primary care, and that is being done with same as cardiology. As our own experience, there's about 30% of telemedicine that's being delivered, and you'll see that on average, there is about a 30% reduction in the care. Or maybe we could think of this as a surrogate for the access of care for these patients. And then the next graph is a little bit busier, but you can see, so this is graphing what are the diagnoses that are being seen via telemedicine. So similarly, the construct of the X and Y axis, you'll see the mental health diagnoses are being seen most with through telemedicine, and cataract, fracture are least with telemedicine, but more or more loss or more reduction in care during COVID. Interestingly, you'll see chronic diseases such as hypertension and diabetes, because there is less telemedicine care delivery. There has been about 30% reduction in these diagnoses being taken. So these patients are not well being taken care of versus those with mental health diagnoses, because they're being seen through telemedicine modalities. Those patients hopefully are not being not seen or ignored. So here I want to pause for a second and ask my dear friend and fellow alum, Dr. Lisa Martin. I'm gonna unmute you, but I want to ask you these questions, put you on the spot, but give you some time to think about your answer and come back after Dr. Huo's presentation. So I know that you're a class of 83 at Yale, and you're a PhD in clinical psychology. So I want to ask you whether your practice is reflected on these slides, number one, and number two is, do you, if that is so, that you're predominantly taking care of patients through telemedicine, do you worry about a compromise in your ability to heal your patients without being able to see them, right? As a clinical cardiologist during medical school training, we're always taught about the power of touching a patient. So we do physical exams, but I feel like my stethoscope is really my accessory because of all the technology that helps me. But my ability to see the patient, shake their hands, put my hand on their shoulder when I'm listening to them, when I'm examining them, I think there's significant power in there. So I want to ask you, for your patients, do you worry about that? And moving forward, do you plan to stay with telemedicine? And if so, how are you going to change your business model? So there's a lot of questions for you to think about.
Okay, I will think.
For the challenge. So thank you. Let me go. So so in summary of that last paper, what they found very similar to our own data is that 30% of, there was a 30% of telemedicine use overall in the first half of last year. And compared to pre-COVID, there's a huge increase in the amount of telemedicine. And they saw a disparity in communities with worse poverty level. Telemedicine use was lower. And they saw a large variation across specialty and across diagnoses that I went over. And mental health saw an 11% decrease in care versus chronic disease, which is, to me, to a cardiologist, very concerning, a 23% or 31% reduction in care. So in my mind, there are three key questions moving forward, looking at telemedicine in the delivery of care. Number one is, will regulatory bodies and payers continue to support this kind of care? And secondly, who would benefit most from telemedicine use? We all ended up, doing about, well, not we all. The primary care and cardiology, for example, are doing 30% telemedicine, but is that the right number? And how did we decide who we see in person and who we see via telemedicine? And the third question is, how do we make, and this is a question for the business people and the technology people in the audience, is how do we make telemedicine sustainable beyond COVID-19? So with that, I invite my colleague, Dr. Huo, to present his thoughts with the Chinese perspective. So Chelsea, could you make Dr. Huo a co-host so that he could share his slides, and I'll stop sharing. Because I think the Chinese experience really helps us understand what are the potential, because they're addressing a different set of needs with a different timeline and success. And my sense is that even though our challenges may be different, telemedicine as an answer may have very similar role. So I look forward to hearing from Dr. Huo. Over to you. We can see your slides, so if you want to put it in presentation mode.
Thank you, Xiaoyan. Did you hear me?
Yes. Yes.
Okay. Good evening and good morning, everybody. I'm very glad to be a part of Yale Alumni for the speaker, especially for this session, to share my personal experience with telemedicine in China. Actually, telemedicine in China have a long term of development from the government and administration, and also from market, from hospital. We have a learning curve. Actually, we have a lot of time to struggling for the conceptual framework, for the market potential, and also we have a lot of achievement so far. Actually, we can see the graph the draft from the 20 years. As a beginning, yes, only some company to have a telemedicine company. They have a group to give a service of telemedicine. Actually, we as a cardiologist, the physician, they have the APP for the physician consultation. But for the government, they are a little bit worried about the management or the administration, monitoring of the telemedicine. So the Senate Council have a document called vigorously advancing the Internet Plus action. Actually, 互联网加. Actually, it's a kind of the document is very cautious. After that, the administrative authority, like the National Health Commission, they think over about the administration of telemedicine. So in the year 2016, 17, actually the telemedicine is not, they have a more limitation than before. So very strict rule at that time. But after the year 2018, the State Council have another document. They realize the telemedicine is maybe is a future as of medicine, is a part of medicine. So they have the document on promoting the development of Internet plus healthcare. And also in the same year, they have some the regulatory policy for the from the National Health Commission on the Internet diagnosis and treatment, Internet hospital, and remote medical service. Like the Xiaoyan talk during the pandemic COVID-19, the National Health Commission gave a greatly promoting the telemedicine, especially during the pandemic. They give a lot of subsidies, especially some policy for the company. They have a lot of activities. So the consultation on the telemedicine goes up very rapidly. We call it the explosive growth. Conceptual framework of internet healthcare have a three parts. One is a online hospital operation for the medical service. The second is a pharmacy prescription online together with offline pharmacy. And also another important the insurance reimbursement for the telemedicine. All the three parts now in China, we have a document from government administratives, and also we have some guideline or consensus from our societies. So as my personal experience, we have a virtual hospital. We are already operating for 4 years. Really, we think the telemedicine has a great market potential and have a great benefit margins, especially for the online consultation, prescription management, and also estimation for the internet medicine market. will exceed the 100 billion RMB. And also we estimated for the tier 3 hospital, tier 2 hospital, the penetration for the inpatient or outpatient totally of 8% to 15%. My personal experience with 39 virtual hospital is founded by Longmaster Information and Technology, established in 2016. Our mission is to improve national healthcare quality by directional referral system and improve quality of care, especially in the rural area. And also give a lot of benefit to the patient and reduce the cost of health care. And also we are by the consultation and also by the telemedicine in clinical practice, we improve the doctor's professional proficiency. So increase the compliance of the patient, the safety and the standardization and professionals. So our hospital now have a 2-layer of business. Is a focus on the patient, especially on the county or the rural hospital, with the consultation established of the different specialties aligned in the telemedicine hospital, virtual hospital, improve the specialty care and build the virtual hospital platform as a more specialty join us and grows big and big. But also we have a focus on the physician. Through the consultation, we have a physician the training and how to teach them the patient management and also promote the income of a physician and have a physician training and leveraging the pharmacy network with prescriptions. This so far we reached the 27 provinces in our country, and also we have 21 specialties involve 10,000 hospitals and 400 pharmacies. We have 2,000 experts active on the platform. Total have 10 million patients and 3 million consultation and 200,000 treatments. And this treatment means from the online hospital to the offline hospital treatment. So for the example of our program and service in the different specialties like urology and oncology, severe cardiovascular disease, diabetes, neurology, gynecology, obstetrics, and also pediatrics. Totally the 21 specialties. These are some picture in our practice, and also through the last 4 years, we have a measure our outcomes and how to evaluate the virtual hospital, the KPI, the success. We have a 2 category for assessment. The clinical index is a number of patients, inpatient, outpatient encounters, the procedure utilization, number of routine and the complex of surgery, number of approved diagnosis. Second is training, education. a number of remote reference online rounding, on-site training, agreement in diagnosis and treatment of plan with expert. Third is financial, the hospital revenue. The fourth is publication of a book in a virtual hospital, especially with set up a standardization for the telemedicine. This our book regarding to the standardization in the practice of telemedicine, and also we set up a national standards already issued document for telemedicine in our countries. So summary, COVID pandemic has been a catalyst for the change. They really have a significant market potential for the telemedicine. The technology is ready, but reimbursement is crucial to the adoption. Telemedicine should be an enhancement of mainstream care delivery. And also, the digital health may be significantly benefit the rural healthcare access, care quality, chronic disease management, and improve population health. That's all for my talk. Thank you.
Link is not my link.
Nam?
Mama,
Thank you very much, Dr. Huo.
Mama.
Maybe Dr. Huo, if you want to unshare your screen. So since I asked the first question, Lisa, are you ready to answer some of my questions to you? And then we'll go to audience questions. Well, I'll unmute you.
Oh, there we are. Can you hear me?
Yeah.
Good. Good. Well, thank you for the question, Dr. Huang. I think it's interesting what you were saying about the provider's ability, the doctor's ability to connect with a patient, to feel them, to feel the interaction, to comfort them, what we're used to feeling face-to-face with patients, and that connection is very important for healthcare. You asked if I experienced challenged with that with telemedicine, and I don't. I find that when we look, as doctors, as my therapy work, when we look at patients through the video, when we want to connect with them, when we show that, it shows on our faces, and we can still have the same warmth and connection and share their concerns, and they can talk freely, and that it's just as strong as when we're face to face. I'm very encouraging of practitioners understanding that, because I think telemedicine is very important and we must promote it. We'll be able to help more people. I think that for patients, their brains can adapt, like their personalities, their beings can adapt to feeling connected to someone, to their doctor on video. Fortunately, as humans, our brains are very adaptable. And we have been with technology for so long, with video technology, that people are feeling that. I mean, young people, teenagers, children, always are connected to technology. So for their brains are actually rewiring so that it's natural to connect to friends and family and their doctors through video. And we're evolving. Homo sapiens evolve. Our brains evolve thousands of years ago when we developed reading and writing. We got used to that, and we're doing the same thing now. Our brains are becoming used to connecting with people through technology, and that's going to just grow over the years. So I encourage doctors to understand you can make the same connection with your patients through video. They can feel it. The patients can feel it when we're looking at them. So yes, you want to touch them on the shoulder and you want to pat them and shake their hand, but that can be done with your face as well, and when you're talking.
That's encouraging. That's good to know. Maybe briefly, how about your business? If you were to switch your practice to telemedicine only, would you change
Yes.
your business model? Get rid of your.
I am already considering doing that. I had started learning about telehealth and practicing telehealth before COVID. So maybe about 5% of my therapy clients I was seeing already on video. So when COVID came, it was an easier transition for me. I didn't have to find the system and learn it. I was already ready. So I jumped right on it, and it was a very easy transition. And actually it made life a lot easier because I had fewer no-shows for my clients. I think you said some doctors had more no-shows with video, but for me, for my therapy clients, they didn't have to drive as much. They didn't have to look for parking. They didn't have to look for meters because of where I'm located near the city. So I have more clients showing up on time, and we got more work done. And I've been able to see my clients in different places. I have overseas clients. And so I am now, like, I've informed my landlord, my office landlord, that at the end of my lease, I'm not going to renew. And my landlord has adapted because he said, well, I've got something for you. So he's going to offer me the office to use for mail and for conference room use when I need to. And he installed a big TV screen for Zoom in the conference room. So I'm not going to pay full rent, but I am going to pay a licensing fee to still use the space. So I'm transitioning. I'm going to make the jump. Of course, it's easier for therapists and psychologists than it is for many types of practices. But I'm going there.
That's great. I think that's where we want to go too, at least part of our practice. So over to Jia. Thank you, Lisa. We'll follow up more. Do you want to take some other?
Yeah, thank you, Xiaoyan. This is this I learned so much. So thank you so much, Greg, Xiaoyan, and Dr. Huoyong for sharing. So it's a very intense and very rich information. So it's interesting. It sounds like I think from mental health perspective, perhaps the adherence was even improved because people don't have to go through the pain of travel and scheduling, so they can be more adherent. And I think there's a bunch of questions in the chat here. I think Remy, you had some questions for Greg. I want to see whether you want to ask here.
Sorry.
Thanks, Remy. Sorry, I should have given you a warning.
Sorry, and I have terrible lighting right now. No, there were probably more thought starters than specific questions. I mean, sorry, I raised several. I mean, I guess two various topics, so Greg can jump on whichever one he would like to. One is sort of the question of the whole business model, and with that, kind of the related legal implications if you're offering, medical consultation to a patient through telemedicine versus, in person. Like, I'll give you an example. Actually, as a caregiver, my mother lives in New York City typically, but we actually shipped her up to her sister upstate where there were fewer people and sort of less initial risk for her. She had some issues with her eye and needed to, speak with her eye doctor. He tried to do a consultation by, with via Zoom, looking at her eye and talking to her, and that was challenging. I mean, in the end, we were able to go see him once things were calmer in the city. But, in that example, you know, if someone gets a consultation through a telemedicine appointment and then maybe perhaps is misdiagnosed, right? How can that be handled, right? I think there are questions about the cost, you know, of such, you know, if you're giving consultation versus in person versus telemedicine. So that's sort of one area just to think about with the business model. Totally separate from that, I also raised the question of kind of equity through teleconsultation, and specifically, you know, I've been spending a lot of time thinking about education and educational access, and there are challenges with communities where they may not have the devices they need, or they may have the devices but not the connectivity. So depending on where you're shifting your business model and how much is going to be towards telemedicine, you know, are we potentially isolating those people even further? So again, not questions, just some topics for thought. But on the flip side, I just want to say to all of you, incredible work, you know, pivoting so quickly to be able to work in a very different way. And also not only to do so from a medical care perspective, but also just in terms of tracking the outcomes. I think that's so important. And I think a lot of other industries and organizations can learn from you all. So thank you for sharing all of this.
Thank you, Remy. Thank you. Greg, do you want to comment to Remy's comments?
I mean, yeah, you know, those are complicated questions and complicated issues. I don't know if I can address all of them, but you know, what that brings to mind are the macro forces at work here, which are that, at least in the United States, that healthcare costs in general have reached 18–19% of GDP, which of course everyone knows is far greater than just about every other industrialized nation. And simultaneously, quality is not nearly as you know, at the level of where we think it should be, given the amount of expenditures that we're having. So one of the expectations is that the use of technology will drive a number of things, such as improved equity and improved access. Now, is it perfectly, you know, equal for all parties? No, of course not. But this is, you know, this is part of the disruptive technological transformation that happens in all industries and across society. As technology gets less and less expensive, then eventually the accessibility to various services becomes available to more and more people. And so, indeed, in the United States, lack of access is a tremendous issue. You know, in general, the use of technology and telemedicine is thought of as one of the equalizers, both from a telemedicine for sort of, you know, the reasons stated, convenience, accessibility, but also digital medicine is seen as one of the ways to improve access and actually improve diversity, you know, for the same rationale that technology has, if it's designed appropriately, is, can be used to create equalization factors compared to other, other ways that healthcare is delivered and accessed.
Thank you, Greg. I know that it's been it's probably been also late for some colleagues here. So I want to ask whether the audience have any burning questions for Dr. Huo, given all this very impressive growth in the scale of telemedicine in China. I wonder, I see also my prior physics professor, Professor Shivakumar here. So I'm just taking a little bit advantage of being the host. I want to ask you, you've been looking into the health strategy, virtual health, and technology in-house. Want to ask you whether you have thoughts you'd like to share with us.
Definitely. I think telemedicine is going to be a very important channel, and it will get strengthened if we have a data backbone that allows people freer access to health data and also to consumable health knowledge. Because the other thing we don't talk about here today is, in addition to telemedicine, there's perhaps been a lot more extensive use of Dr. Google and people trying to self-diagnose and solve their own problems as they're isolating. So I do hope that these technologies will create a more pervasive engagement of individuals and allowing and helping individuals to take more responsibility for their own health and get supported by the health system in order to do that well. So I see a lot of exciting times ahead, and hopefully people will embrace change and take advantage of the new capabilities that are becoming available.
Thank you very much, Dr. Kumar. So you're right, data. So it is an important backbone. And I think one of the future, like telemedicine, digital health in 40 years, one of the key attributes people are dreaming about is the super interoperability. So the ability to really have data when you need it, and the ability to interoperate. Maybe I just want to make a last comment. I know it's really late, and early in this session, somebody mentioned the ability to go see a doctor, a specialist in a city is very different than in a rural area when you have to drive 100 miles to see a specialist. So I want to point out and remind us that Dr. Huo actually in his work, telemedicine work, there's a lot of focus in rural area, really reduce that inequity and improve the access for people in the rural area. So I wonder whether Dr. Huo, you want to make a further comment.
In China, so far, we have a government policy for the telemedicine in the rural area for the primary care. Already, we have a telemedicine service in we call the Xiaoyan. Actually, it's the Tier 1 hospital. It's a Tier 1 hospital. The most Tier 1 hospital have a connection to the county hospital. We call the area center hospital. They have a telemedicine service. But in the few provinces, they already have the reimbursement policy for the telemedicine. Even have some the policy for the prescription online. So now it's in some provinces already have the telemedicine service is quite high standard. I mean, in China now, but I think still we need the government support, and we also need some company, lot of funding for the further development of telemedicine, especially for the rural area. Thank you.
Thank you very much, Dr. Huo. Thank you for sharing. I know you have also a busy schedule, need to get back to the patients. I want to, I see there's so many questions coming. We're going to save it, as Xiaoyan mentioned, this is only the first of the series, so there will be more coming. And thank you so much for your time, your energy. And we've learned a ton, and we understand there's such a pivotal change in telemedicine, but the topic is so complex, from patient experience to the type of specialty to payment models to data. So I'd like to wrap it up, given that it's pretty late now. Thank you all for joining, and hope to see you soon in our next series.